So the question is if there's any role of chemotherapy or immunotherapy in subsequent line therapy of patients with ALK-rearranged lung cancer when we have multiple options for targeted therapy. So I think we are still not curing anybody with metastatic disease that has an ALK rearrangement, even though it's wonderful that we have high response rates with targeted therapy and multiple lines of targeted therapy work. Eventually, every patient who maintains a good enough performance status and has exhausted multiple lines of targeted therapy will become a candidate for chemotherapy. The issue of immunotherapy is more problematic because so far, whatever data we have accumulated shows that immunotherapy doesn't work very well with patients with single driver mutations. Immunotherapy works better in patients with high tumor burden, patients who have lots of mutations, usually patients who have had carcinogen exposure or prolonged carcinogen exposure inducing multiple mutations in cells causing cancer, such as in case of melanoma, exposure to UV radiation, or in case of lung cancer, carcinogens in cigarette smoke. So patients like ALK-rearranged patients who are never smokers or former light smokers and have a single driver mutation are unlikely to respond to immunotherapy.
The use of immunotherapy in combination with ALK inhibitors is still highly experimental and certainly from my standpoint, not ready for prime time. Early reports of phase 1 and phase 2 studies combining the new checkpoint inhibitors with ALK TKIs have been rather worrisome with heightened toxicity. And this extends not just to ALK inhibitors, but to EGFR inhibitors. A perfect example are the early work looking at osimertinib, T790 drug in combination with durvalumab, where we observed really untoward toxicity, heightened pulmonary toxicity, much more than we would have predicted with either agent alone. So outside of a clinical trial, I would not attempt to either graft on immune checkpoint inhibitor onto a TKI or necessarily combine it with a second generation TKI. It's my gestalt over time that the immune checkpoint inhibitors don't work all that well with oncogenic drivers. And just to give you an example, we evaluated 175 patients receiving nivolumab from the time it was first approved in March of 2015 to 1 year later, March of 2016. And uniformly, individuals with either EGFR mutation or ALK translocation, we saw absolutely no responses in that group. So the standard approach in individuals who are now ALK inhibitor refractory, I've gone through 2 or 3 different ALK inhibitors, remains chemotherapy. And in that group, I would favor a pemetrexed combination if there's no contraindication, if renal function is adequate. Generally, pemetrexed with carboplatin, with or without an angiogenesis inhibitor, usually bevacizumab. I'd be much more favorably disposed toward looking at angiogenesis inhibitors in combination with TKIs. And again, one of our examples comes from the EGFR literature, prospective randomized phase 2 trial from Japan that looked at erlotinib alone or erlotinib combined with bevacizumab, and in which we observed about a 6.5, 7-month improvement in progression-free survival that seemed to be independent of the nature of the EGFR mutation. I predict similar findings for the ALK inhibitors, although we've not actually seen the data as yet.